high yield topics. As far as high yield topics go, neurocutaneous disorders is really, really high. It's one of those things you realize when you get older and they start asking you to write the questions. They love pictures. Anything you can make a picture of, you're going to be tested on far more frequently than you would otherwise. And anything that you can ask a specific question and have a specific right answer to, they're going to test on also. The people writing these tests are not evil geniuses. They're people doing other stuff, and they're trying to get a question and answer that's obvious and will pass without having to redo anything. So just keep that in mind, and it can help whittle down what might be tested more than logically from a clinical perspective you think it might. So, let's see. So you have a 16-year-old child that comes into your office complaining of vision changes in the left eye. On exam, you see the below stuff. Mm-hmm. It isn't. Okay. Let's see. Resume slideshow. Will that do it? I don't see it on here. Okay. All right. And I hope our people viewing remotely are also seeing the progression of the slide, because it isn't showing up on my screen. All right, so case one, we've got a kid showing up with loss of vision in the left eye. You see this on exam. What might this person have? What are these things called? Yeah. So I'm really worried this isn't showing up for these people. Is there any way you guys could contact them? Because I can like manually try to make it progress, but.
We can see it.
You can see it? Okay.
Yeah.
All right. Okay, so yes, what we have are lesion nodules, cafe au lait spots, neurofibromas. We'll talk about the progression later on, but you're probably unlikely to see that many neurofibromas in a teenager, but good. So what might you see on imaging in this kid with concern for vision loss in the left eye? And it's not progressing anymore. Oh. Tell me if it does anything for you guys. It's not at all. So would anyone care to come up here and fix my computer? So I'm having to progress manually for them to see, and then you guys aren't seeing.
Okay.
So we can try just coming back out of it maybe.
Try
And,
doing a different.
yeah.
Were you in this one?
Let me see if that works. Progress, let's progress and see if that works. Okay, so it's working for you guys. Hopefully the remote people, are you guys seeing an image now?
Yes.
Yeah.
Okay, problem solved. Okay, so what might this be? Optic glioma. And yeah, that's one of the primary things we're going to worry about if somebody has complaints of loss of vision in an eye. Most often, this is a benign tumor, but it can cause all sorts of issues because you've got tightly packed space there. This is your optic nerve. And one of the things you're really going to want to watch for is progression, because if it crosses the optic chiasm, the child can go. So sometimes they can transform into a malignancy, but this is really rare. So neurofibromatosis type 1 is the neurofibromin gene. It's autosomal dominant with 100% penetrance, but quite variable expression. So if you have the gene, you have neurofibromatosis, but you may just have one cafe au lait spot, or you may be one of those poor people who have bone defects, multiple surgeries for the neurocutaneous fibromas that have become malignant. You may have associated cancers. You know, you can't tell from the gene itself. And even within the family, there doesn't seem to be really any predilection as far as, well, mom's had a really mild case, so the baby will. It's just hit or miss. We don't understand at this point why there's so much of a difference. So the findings become more apparent at age. Oftentimes when kids come in and there's a family history, the child just has a few cafe au lait spots. And so you can make a presumed diagnosis based on the fact that they have a first degree relative. But you can imagine an infant that comes in without a family history, you're really stuck as far as trying to make a diagnosis. With time, things become more apparent. The cafe au lait spots become bigger. They get more of them. Then in early childhood, they start getting inguinal and axillary freckling. And then you start developing potentially the neurofibromas under the skin, the cutaneous neurofibromas, or plexiform neurofibromas. And you may also see the leash nodules develop. And occasionally you can see this younger. I have had a few preschool age kids that have had those. Most of the time, though, you're not going to see it in that age group. So with a young child with no family history and a whole bunch of freckling, the only way you're really going to be able to do this is to get a genetic diagnosis. Greenwood Genetics doesn't test. Invitae does, so we just submit them. Things to watch out for. Interestingly, you know, we see them regularly, and most of the time we don't do a whole lot other than ask, so, you know, have the appearance of any of these changed? And if they have, we send them to surgery. And we ask, oh, have you had staring spells or convulsions? But really only 7% of people with neurofibromatosis ever develop seizures. So yeah, that's higher than average, but it's not super high. Things that are much more likely, learning disabilities. Most people with neurofibromatosis are going to have a lower IQ than their non-affected relatives. Most of the time, this doesn't reach intellectual disability, but very often they have low borderline IQ. So like scoring an 80, 70, that sort of range stuff is not going to get them services through the school district, but it nevertheless is going to be problematic. They have an increased risk for learning disabilities, ADHD. If there's anything that plagues them in the younger years, it's probably going to be that. Now, they are at increased risk for a multitude of other tumors, some of them being neurologic, like meningiomas, gliomas, but can also be leukemia, pheochromocytoma. By no means common, but much more likely to have it than the general population. We do need to watch the neurofibromas because the neurofibromas can transform into malignancy. The things we watch for with that is, are the lumps getting bigger rapidly, or do they hurt? And those tend to be signs that something nasty might be going on. And so you need to get somebody else involved. So case 2. Case 1, by the way, most likely you're going to see that compared with any of the other neurocutaneous disorders. About 1 in 3,000 people have neurofibromatosis. So you're going to have people walking into your clinic with this. The rest of these that we talk about, a little bit less so. So you have a 2-year-old that comes into the clinic. They have seizures. On history, they had a heart murmur that was detected in infancy. The child has developmental delays, and you're looking at them and you see this on exam. Yeah. So what do you see? Yeah, your ash leaf spot and your sebaceous adenomas. So this can be easy to pick up, or it may be hard. It's really going to depend on the skin tone of the patient and on the degree of hypopigmentation. The same is true of cafe au lait spots. I have some kids that are Caucasian that have cafe au lait spots so light that when they tan, you can't see them. So definitely, if you're ever questioning things, try to get a woods lamp. I know there are people out there who have this that we just don't pick up on because the spots are not significant enough difference from their skin tone for us to pick up, and that we don't find out about it until, you know, years later. So the woods lamp can be your friend. You may see confetti, ash leaf spots present at birth. You may not see much of anything though. And as time progresses, these are kids that are going to develop more as well. So the chagrin patches and the plaques, the ones that have the sort of rough surfaces, you're not going to see those at birth. They'll develop later. The facial angiofibromas oftentimes develop a little bit later. Many times people think it's acne because it's developing in mid-childhood. They think it's like an early acne. The periungual fibromas and fingernails, that comes later. There can also be other non-specific skin lesions. So even though we think of hyperpigmentation with tuberous sclerosis, you can also have capillae spots. You can also have just molluscum or skin tags, increased amounts of those. And then poliosis, where you have that patch of like white hair. You can see that as well. As far as ophthalmologic findings, you can see hamartomas of the retina. You can have colobomas, which will be really apparent, on exam in the office, whereas a retina exam might not be. And then angiofibromas of the eyelid, just kind of like tags hanging down off the eyelid. So what might you expect to see on imaging? So number one thing that you're going to see, cortical tubers. I know of one case where a child had genetically confirmed tuberous sclerosis and had no cortical tuber, but I've heard of one. Almost everybody is going to have it. And subependymal nodules as well. And these cortical tubers especially are going to be the things that are going to cause problems as far as seizures, because they can grow in size and become problematic. But the number one major thing you're going to be looking for in imaging is this big guy in the center, which is a subependymal giant cell astrocytoma. And those are potentially deadly. This is an autosomal dominant disorder with variable expression and complete penetrance. New mutations are around 75%. So whereas with neurofibromatosis, new mutations were maybe 50%, very often you're going to have a parent that's affected, much less frequent with tuberous sclerosis. In fact, I'd say 75% is probably low. There are two different genes that are often the cause of it, TSC1 and TSA2 on separate chromosomes. There are a few other spots on chromosome 11 that have also been associated. And then occasionally we get kids with what looks like clear clinical tuberous sclerosis, but with a blank genetic workup. And I'm sure it's something we just don't know about yet, but it does happen. So you may have tumors, not just in the brain, but in the heart, the skin, the kidneys, eyes, lungs. One of the first signs many times is a child has a murmur in the NICU or the nursery. And we come in, we examine the kid. They have a few confetti spots, but nothing that you'd be worried about otherwise. And then we get imaging of the head and yikes, there are tubers. So the other tumors oftentimes do develop with time. So you may not have the tumors in the kidneys yet or lungs. So these are going to be monitored over time. We have a tuberous sclerosis clinic here. Most places, large hospitals do, because they need a multidisciplinary following over time, because things can get much worse. Most kids who have tuberous sclerosis have seizures. They're at high risk for infantile spasms. This is the one case where, other than treating with ACTH or prednisone, we may go to something else first. That would be vigabatrin. They are also at risk for complex partial epilepsy because of all those tubers causing problems. We know that tuberous sclerosis seems to always be caused, regardless of the mutation, by a disruption in the mTOR pathway. Everolimus blocks that. And there are also some other similar chemotherapy agents that do, but everolimus is the only one that's approved. It seems to help as far as treating your subependymal giant cell astrocytomas, the kidney tumors, and does seem to actually potentially decrease seizure frequency as well. Some indication it may even help with behaviors, not necessarily improving intellect, but improving their functionality, definitely. So I think more and more people are using everolimus as a treatment. The issue, of course, is it's a chemotherapeutic agent, so there definitely are risks associated with it, and they're going to need to be monitored closely. Most people with TSC have severe ID, autism, severe to profound. I know of one kid, and there are probably a whole lot more walking around that we just don't bother to test, where I was treating her brother. We thought he probably had like a channelopathy of some sort, really hard to control seizures. I did a whole workup, couldn't find anything. We tested the family to see if they could help us out. And sister, who was away at college, tested positive for TSC. She got scanned from head to toe, nothing other than one hypopigmented macule on her shoulder. So there is variability of expression, and there are some people who are very lightly affected. As far as I know, she still doesn't have any signs. So it's possible. So case 3, you have a 3-year-old come into clinic. They report child was born healthy, aside from the noted birthmark, was moving arms and legs equally, later on developed seizures and hemiplegia, and on exam you see this mark. What might the patient have? Yeah. So on imaging, what you're going to be looking for is leptomeningeal enhancement. And this is due to the venous capillary defects unilaterally, and it's going to be on the same side as your port wine stain. The reason this is important is because sometimes kids present before they've started having strokes. So they don't have seizures, they don't have hemiplegia, but you want to know beforehand. And you should be able to see it with an MRI with and without contrast. That contrast is going to help you see that abnormality and the veins on that side. Did it change? Okay. So this is rare. And just because you have a port wine stain on your face doesn't mean you're going to have STURGE-Weber syndrome. However, your risk increases quite a bit. Hello? The risk increases quite a bit when it's located in the ophthalmic branch. So spots elsewhere on the face or the body are much less concerning. It's caused by a somatic mosaicism mutation. So only the affected side of the brain and that eye and the skin are affected. If you test elsewhere in the body, you're not going to find the mutation. So, and due to this, clearly, you know, it doesn't appear to have any sort of genetic predilection because this is a mosaic defect that takes place later on. So the capillary abnormalities are what leads to the stroke, and the stroke in turn leads to cerebral palsy and seizures. Increasingly, people are trying to treat aggressively with low-dose aspirin and with like Keppra, more benign anti-seizure agent before any symptoms develop. There does seem to be some indication that that helps at least put off the stroke and possibly limit the degree of disability from the stroke. There's a lot of other interest as far as medications. I don't think any of them have reached the point of being, you know, standard recommendations. So we're going to get into some more obscure ones, but believe it or not, they are listed as testable material in your content specs. So incontinentia pigmenti type 2, also known as just incontinentia pigmenti. They try to be very confusing with this one. We're going to call it IP from now on. So this is really interesting in that it's one of 2 main disorders that follow the lines of Blaschko. Are you guys familiar with those as well? These embryonic pathways that cause, you know, if you have any sort of mosaicism, you're going to see these swirls on the skin, makes these kind of really pretty swirly patterns. Sometimes you see this in totally healthy individuals. So this is just your lines of embryonic stem cell migration, or sorry, cell migration. In IP, you're going to see a rash develop, and it's going to progress over time. And this is what is going to differentiate it from the other one that we talk about later. So at first, the skin looks normal. Then at birth, or probably within the first week or 2 of life, you start to see these vesicles erupt on the skin. It looks herpetiform, but again, it's along the lines of Blaschko, so it's kind of stripy. That's going to change to more of a warty type look. And then after several months, you're going to end up with a hyperpigmented flat stripe. And then that's going to be the same throughout childhood pretty much, but then into adulthood, you're going to start to have hypopigmentation of this area with associated atrophy of the underlying skin. You have hair loss of the affected areas. And you could also have effects probably vascular related, such as mini infarcts, which can cause seizures and other neurologic morbidity and mortality. This can be present in infancy, can happen later in life. You're going to want to get neuroimaging with this, but there are definitely many people who don't have any sort of neurological impact. If you are going to see any neurologic symptoms, seizures, of course, but also other things that you can think of being associated with stroke. So hemiplegia, spasticity, and then intellectual disability. The eyes are really involved. You can have bone involvement, particularly when people get older, they start like having issues with their teeth and their jaws. But some people can be really high functioning. I think the former CEO of J.Crew has this. She's had to have all of her teeth replaced. But clearly high functioning individual when she left the company tank. Genetics wise, it's X-linked. You're mainly going to see this in women because it's lethal in men. So our other disease that follows the lines of Blaschko is hypomelanosis of Ito. And unlike IP, it doesn't really change over time. So the causes are a little more variable, but what you're going to see, and it's going to be present from birth and largely unchanged, is hypopigmented lesions. And so you're going to have stripes. Now, this may not be as apparent as birth as it is later on because people's skin darkens as they get older. So it may become more apparent, but you should still see that striping present at birth. There's no pustular, like blistering stage. There's no warty stage. It essentially stays the same. It can be really hard to pick up, and it may not affect the whole body. Many times it will only affect like one arm or maybe hemibody. And in that case, the areas that are affected, not surprisingly, are going to be underneath. So there is an increased risk of seizures in ID. Exactly why isn't totally clear. You can have eye effects. You can have musculoskeletal effects. Sometimes people will have like a decreased size of the affected arm and decreased functionality. The rest of the body is totally fine. You can also have vascular abnormalities. Sometimes cardiac and genitourinary, but much less likely. And some have been linked to some X-linked factors, but others, we really have no idea exactly what's causing it. And that probably represents some of the heterogeneity we see as far as comorbidities. It's due to chromosomal mosaicism. Clearly, you know, you have the different cell lines that are rotating and migrating all over. Therefore, you need to karyotype the skin to make sure you're getting the affected area. So neurocutaneous melanosis. So this one is most evident, particularly at birth, by having like generally almost like a cape-like appearance, this huge hairy nevus over the back. If it associates or if it spreads up to the neck, you're more likely to have issues from it. We'll get to that later. But anytime you see this, they definitely need a workup. You're going to have the cape. You're going to have multiple different satellites around it. However, they recommend that you do a workup even if you have 3 large hairy nevi, regardless of location. And so one of the things that can happen is that you have these melanocytes that are causing it. They can directly infiltrate into the leptomeninges, and this can cause you to have abnormalities in your cerebral spinal fluid outflow. So this can be a direct cause of hydrocephalus. They also seem to be at an increased risk of aqueductal stenosis, which I would think would be unrelated to the melanocyte migration, but I don't know. You can have cranial nerve dysfunction, which again, sometimes can be direct infiltration. And you can have spinal cord and root involvement. Clearly, the higher up the findings are, the more likely it's going to be cervical involvement. You're going to have more issues from it, but it can be all the way along the spinal axis. And this is one that is definitely going to be present at birth. And for the most part, is going to be stable over time, but you do need to watch it. You can imagine, you know, this is something that you're going to need to have oncology and dermatology associated with from the beginning. So this is not all of them. These are the ones you're most likely to be tested on though. So neurocutaneous syndromes are disorders of the central nervous system that also result in lesions of the skin and eye, as well as all other organs of ectodermal origin. The cutaneous stigmata may be present at birth, but they may develop over time, or at least change in presentation over time. And a lot of the comorbidities become apparent over time as well, may not be present. So how are we doing with time? We got a little bit of time. So I'm going to just go over febrile seizures because I feel like we never touch on that, and they do love to test on it. So you have a 12-month-old that comes in previously healthy, has a brief generalized seizure after a day of fever up to 104, no family history of epilepsy, baby's developmentally normal. You tell mom the diagnosis is blank, and then mom asks, well, what's the risk that he will develop epilepsy later on? What's your answer closest to? So it's 2 to 4%. It's really relatively low for a simple febrile seizure with no other risk factors. We have 3 to 5% of the US population will have a febrile seizure. There is a genetic component. We'll get into that a little bit later. And the definition is basically 3 months to 5 years of age. This includes 5+ up to 6. The cutoff is at 6, and it needs to be associated with a fever, but without evidence of intracranial infection or any other triggering event, hypoglycemia or what have you. So simple versus complex. What makes a seizure complex is having a focal aspect at onset, having the seizure last greater than 15 minutes, or have the seizure, more than one seizure in 24 hours. Of these, the focal onset seizure is the most important because that leads you to think, hey, there might be something in the brain causing this. And so these are kids that definitely need an EEG. Generally, anyone with a complex febrile seizure eventually gets an EEG, but I definitely get one with them, and they're probably going to end up with imaging as well, just to make sure there's not some goober in their cosmos. The other two are listed mainly just because they do increase your risk of developing epilepsy, but not a huge degree. So what are the chances of a child having a febrile seizure in the first place? Risk factors include daycare attendance, a family history of febrile seizures, being in the NICU, having developmental delay. None of those are particularly surprising. Things that cause fevers and cause fast spiking fevers, such as HHV and influenza. There does seem to be genetic component. And you can see with twins, monozygotic twins are much more likely to have it if their sibling does than dizygotic twins. Definitely there's some genetic component. And then there's also generalized epilepsy with febrile seizures, which is sort of an in-between diagnosis where kids continue having seizures in past their 6th birthday, and they can have them without having fevers, but then the seizures generally go away by 18 years. And so it's a more benign condition than most of your traditional epilepsies, and genetically it seems to be linked. Yeah. Not in and of itself, but it has an increased risk factor for developing epilepsy, period. So we tend to investigate them further. But as far as a strict definition, no, that's not included. But you'll see it factors in as far as risk. So recurrence risk of febrile seizures, around a third will have a second febrile seizure. Of those that have that, around half will have another one. Most of the time, if you're going to have another febrile seizure, it's going to happen early. So half within the first 6 months, the vast majority within the first year after that first seizure. So whenever we have a kid who had febrile seizures at 2 years of age, didn't have anything, and then comes in at 5 and has a seizure, we're thinking, hey, something else might be going on from the beginning, even if they have a fever, because this isn't the typical pattern. It's certainly possible, but not typical. Factors that affect recurrence risk: the younger you are at the first one, the more likely you are to have further ones. If there's a history of febrile seizures in the family, and also low-grade fever overall, I don't know that they would test you on exact numbers. Most of the studies have been either above or below 40 degrees Celsius as the cutoffs, but it seems to be more of a continuous pattern, you know. And probably what's going on is that at least some of the time, some of the febrile seizures are not actually febrile seizures, and that's why the low fever is triggering them. And then illness frequency as well. If you have a child who never gets sick and never runs a fever, it's hard to have a febrile seizure. So risk factors by age, don't memorize these numbers. It's just showing you that your relative risk increases dramatically with the number of risk factors you have. And if the febrile seizure occurs early in course of the fever, you have increased risk compared to later on in the fever. Various things that are not affecting your recurrence risk, the type of illness, gender, daycare attendance, although we've already said you're more likely to have a febrile seizure in the first place with daycare attendance, and you're more likely to be sick if you attend a daycare. And then complex versus simple does not affect your recurrence risk. What it affects is your likelihood of developing epilepsy as an adult, or child, not further febrile seizures. The routine labs with a simple febrile seizure, really there is not much to do. Lumbar puncture, maybe particularly in the younger kids to rule out meningitis. Keep in mind that a sixth of patients with meningitis present as a seizure and a fever. As the kids get older, you can trust your exam more. It's not routinely indicated. Imaging, you don't need to get that with a simple febrile seizure. EEG, you don't. But if it's a complex febrile seizure, particularly with focal onset, you're going to get imaging. And in reality, with any complex febrile seizure, they're going to end up getting an EEG, which is fine. So febrile seizures in and of themselves, if they do not later develop epilepsy, are pretty benign. The biggest longitudinal study, there was no effects on IQ, no deaths. There does seem to be an increased risk of sleep problems, anxiety, and possibly schizophrenia. No one knows what to make of that. And it is a very small increase, but it was statistically significant. So will my child have epilepsy? Your glorious Venn diagram. So you can see the various risk factors increase your risk, but if you have developmental delays, a family history, and a complex febrile seizure, then you have 23% risk. So, other factors, Todd's paralysis. Well, of course it's going to. Todd's paralysis happens when you have a focal seizure, and it's more likely to happen if it's longer. So. And then the number of febrile seizures you have, okay, of course, the age of occurrence, we discussed that already, and the duration of the febrile seizure. So the longer it isn't like there's some magic cutoff at 15 minutes. An hour is worse than 15 minutes. 5 minutes is better than 10. So outcomes. 15% of patients with new onset epilepsy do have a history of febrile seizures. We do know that there are some epilepsies like Dravet syndrome that generally present with febrile seizures. The thought is not that febrile seizures cause Dravet syndrome. It is that the febrile seizure is the first neurological manifestation this child has of the underlying disorder that will lead to Dravet syndrome. There are also studies showing that people who have really prolonged febrile seizures have an increased risk for mesiotemporal sclerosis, which of course causes temporal epilepsy. What has not been determined is whether or not they had the prolonged febrile seizure because they had the setup for this. However, it's generally standard thought that if someone's having prolonged seizures, even if it's simply febrile, you want them to have a rescue medication. So aggressive treatment of fevers do not prevent febrile seizures. There have been studies where families gave the kids ibuprofen around the clock. They monitored the fevers. If the kid is going to have a fever, it's going to happen anyway. It is going to somehow sneak through. It does not work, and it makes families really agitated and feel bad about themselves. They can give medication to make the kid comfortable. Don't have them stressing out about trying to keep from having a fever. It's going to happen. Prophylaxis with anti-epileptics do not decrease the development of epilepsy. They will decrease the risk of having further febrile seizures, but we've already established febrile seizures are benign. So we know epileptic drugs are not benign. Don't do that. Sometimes if someone has a really high risk of having febrile seizures, we'll recommend that the family give like diazepam orally around the time of the febrile seizure to kind of calm things down. That can help. And of course, having rectal diastat, if they're a little bit above a year at least, can be an abortive therapy. Some medications have absolutely no effect, period, but I wouldn't recommend testing or treating anyway, regardless with like scheduled medications. And so we've kind of discussed that. And so other high yield tidbits really, really fast. So the most common cause of seizures worldwide, neurocystic psychosis, never seen it in a child, did see it in an adult once. But if you're doing anything overseas or if someone has traveled here from elsewhere, it is a very frequent cause. And looking at the imaging, you can see why. Neuroimaging of a child with difficult to control seizures. This is open lip schizencephaly. You could have open or closed lip schizencephaly. I don't think you're going to be tested on that, but clearly schizencephaly, seizures, it's pretty obvious. You know, you've got a migrational defect there, big time. All right, do you guys have any questions? Okay, you're welcome.